please start. Dr. Naveen and Dr. Likita.
Good evening, one and all present here. This is Team 10 from Gandhi Medical College Hospital, Hyderabad. I am Dr. Naveen and my colleague Dr. Likita. Here we are presenting the case on middle third leg defect. Moving forward, our patient Saroj Kumar Shah, 52-year-old male from Medak, farmer by occupation, has come with a cheek complaints of wound over right leg since 1 month. So patient was apparently asymptomatic 1 month back. Patient had reported history of RTA 1 month ago, in which he was hit by a car while riding a bike. Patient sustained an injury to his right lower limb and was unable to stand. Patient was taken to a local hospital where patient was diagnosed with a fractured tibia with open wound, and an orthopedic procedure, that is external fixator, was performed. Later, patient was referred to a tertiary care center for the open wound over his right leg. There was no history of fever, minimal pus discharge present, and no history of any injury to head, chest, abdomen, or spine. Past history, patient has no known comorbidities, no history of any drug allergies. Patient is known alcoholic and tobacco chewer for past 20 years. No significant family history. On general examination, patient is conscious, oriented, kind, place, and person, moderately built and nourished. Vitals, BP was 130 by 79 millimeter of mercury, measured in right upper limb in supine position. Pulse rate was 78 per minute and it was regular. Respiratory rate 16 per minute. No pallor, cyanosis, clubbing, icterus, edema, generalized lymphadenopathy, and gait could not be assessed. Systemic examination, RS, per abdomen, CNS within normal limit.
So coming to local examination, patient was examined in a well-lit room after taking informed verbal consent with adequate exposure. On inspection, the attitude of the limb is slightly flexed to the knee with ankle and plantar flexion. Single wound is seen in the medial aspect of the joint.
Sir. Continue.
Single wound is seen on the medial aspect of the junction of middle and lower 1/3 of the right leg, measuring approximately 5 into 4 centimeters, and its extent is 8 centimeters above the medial malleolus and 19 centimeters below the tibial tuberosity. Margins show healing epithelium and sloping edges, and surrounding skin is slightly edematous. Floor is covered with granulation tissue in the lateral aspect, and we can see exposed tibia with fracture site in the medial aspect of the external fixator is seen spanning the wound with 2 pins above and 2 pins below the wound. On palpation, there was no local rising temperature around the wound site. Tenderness is present in and around the wound. Inspectory findings regarding site, size, shapes, surrounding skin were confirmed on palpation. And movement at the toes, ankle joint, and knee joint are present but restricted. Passive movements are more than active movements. Distal sensations are found to be present, and distal pulsations in anterior tibial artery, posterior tibial artery, dorsalis pedis artery are present. There are no enlarged lymph nodes in the surrounding area. Opposite limb is normal. Donor sites for flaps and grafts were examined on the ipsilateral and the contralateral limb and are found to be adequate. Here we can see the medial view and the wound picture. This is the lateral view of the entire leg and foot, and this is the posterior view. This is the X-ray of the right leg and foot, AP and lateral view, showing the fractured tibia at the middle and the distal junction, and proximal fibular fracture, displaced fibular fracture. So coming to my diagnosis, it is a post-traumatic compound effect of 1 month duration over the medial aspect of middle and lower 1/3 junction of the right leg with exposed fracture tibia having external fixator in situ without any neurovascular deficit. Coming to the investigations, we would like to do the X-ray of the affected limb, send a wound swab for culture and sensitivity, ultrasound color Doppler of the right lower limb, and routine investigations for anesthetic thickness. Coming to our approach, after explaining all of the options to the patient, we have, these are our options. First one is posterior tibial artery perforator based facial cutaneous flap. The second one being the reverse pseudo artery flap. This is a picture, we have, since there is tenderness for the patient, we have extrapolated the bone on the opposite limb and we have marked the perforators. So this is the marking of the facial cutaneous flap based on the posterior tibial artery perforator at 5 centimeters from the tip of the medial malleolus, above the tip of the medial malleolus. This is the video showing in reverse of the facial cutaneous flap. This is the picture showing planning of the reverse rural artery flap, the other option which we have presented to the patient. We are done with the presentations.
So over to panelists now. You can start the discussion and examining the students.
Can you describe the wound, please?
Can I,
Yes, sir, the wound.
can I just take a clarification before we start?
Yeah, yeah.
Yes, sir.
I think I'll ask Dr. Baba. So how are we about to go about this? Each panelist has to separately ask them questions, or all of us have to ask together?
All of you have to ask the questions.
Okay.
Yes, and start the discussion. Total time will be 40 minutes for the discussion and this examining.
Okay. Carry on.
Either one by one you can ask, and better to not repeat the questions asked by one examiner.
That's fine. I just wanted to clarify because
Yes, sir.
originally it was told 10 minutes, like, so I was a little confused. So I think Giri, carry on.
We
Yeah.
can ask one by one. That will be, I think, without.
That's okay.
Yeah.
That's okay. Yes. Dr. Giri.
Yeah, yeah. Can you just describe the wound?
A single compound defect is seen over the anteromedial aspect of the junction, medial aspect of right leg.
Show me
sir.
the
Please
photo. Show me the
show me
picture.
the photo. Show the photograph.
This is the wound.
Yes, yes.
At the junction of middle and lower 1/3 of the right leg in the anteromedial aspect, measuring about 5 into 4 centimeters in its dimensions. We can see margins are show healing. Margins are healing and they have sloping edges. And there's a granulation tissue in the medial aspect of the wound, and we can see the fracture tibia, fracture line in the lateral aspect of the wound. And we can see an external fixator with 2 pins above and 2 pins below. And the surrounding skin is
Floor of the wound?
floor of the wound. It is tibia, fractured tibia in the medial aspects. And
Can you see that fracture? X-ray also you just saw. What is that X-ray? Why you are telling that it is fixed?
yes, sir, I'll show. This is the X-ray.
So you have then how will you proceed? You have told that you will tell that culture sensitivity and all those wounds you will take it. So then after that, what are the things you are going to do before proceeding for any procedure?
First, I'll do regular dressings for the wound, and based on the plasma culture sensitivity report, I'll give IV antibiotics and IV analgesics for the pain. And as the wound improves, I'll plan for the wound care. Regular dressings, I'll do so.
Regular dressing for how many days, or what is in your mind? How you are telling it is already 1 month and patient has come to you and wound is already everything all right, floor is there, only you are seeing exposed bone. Now you are telling that you are going to do the dressings, then after that you will plan or what?
No, actually, patient has come to our hospital after 1 month after he sustained an RTA. So there was initially first discharge was there, sir.
Hmm.
So till the pus for culture swab report is negative, we will do regular dressings supplemented by antibiotics.
Hmm.
Then we'll see whether there is healthy granulation tissue in the bone, and we'll see the status of the bone also.
Acha. But in fact, this X-ray is after 1 month or just after fixator given?
After 1 month, sir, when he came to us.
So you are going to tackle only soft tissue. There is no need to tackle to the bone parts. Is it right or not?
Yes, sir. With dressings, we will be regularly inspecting the wound with respect to soft tissue and bone also.
So you are telling that you are going to do plan for that soft tissue by giving any local fasciculation. Your first choice is fasciculation, no?
Yes, sir.
Yes, sir.
So before that, what are the investigations you are going to do it?
So I'll do routine investigations for the anesthetic fitness, sir.
Hmm.
Routine profile and X-ray of the limb, whether the bone is in alignment or not. This was taken. And ultrasound color Doppler of the affected limb to see the vessel patency, flow, and everything. And repeat pus culture sensitivity.
So your first choice is you have told fascicutaneous flap.
Yes, sir. Sure.
So how are you going to prepare that one? And which fascicutaneous flap you are going to take it? And what is that your axial line, medial axial and lateral axial line of the perforators? Can you tell me?
Yes, sir.
Yeah.
We have based it on posterior tibial artery perforator.
Hmm.
From the vascular axis of the posterior tibial artery can be marked with a line joining tibial tuberosity and the mid-malleolar point, and it is 4.5 centimeters medial to the parallel to this line. And perforators are found 1 centimeter medial and lateral to this line. This is the vascular axis of posterior tibial artery. And we have found perforators at 5, 7, 5, 9, and 15 centimeters, sir, from the tip of the medial malleolus. And we have based it on 5 centimeters perforators. We are doing planning in reverse.
Besides fascicutaneous, don't you think that any other muscle flap or anything can be given for this part of the wound?
Yes, sir, muzzle. We can.
This is the mid. Tell.
Yes, sir. We can go for inferiorly based reverse hemisoleus or peroneus brevis muzzle on the flap.
Here, which one? This is a
Inferior
defect in.
choices. Defect is on the medial side, sir. Inferiorly based reverse hemisoleus muscle only flap can be done.
No, it's your voice is breaking.
Can you repeat it? I can't hear you very well. Inferiorly based?
Inferiorly reverse hemisoleus flaps.
Reverse
Reverse
hemisoleus. Okay.
hemisoleus muzzle only flap.
Or one more you said, no?
Yes, sir. Or peroneus brevis muzzle only flap.
Peroneus brevis. Okay.
Peroneus brevis will come.
Okay.
So you can
Go ahead.
Go ahead.
Any other muscle flaps?
This X-ray image that you can see, no, Likita? Can you describe the X-ray image again? What fractures can you see on the X-ray? And what are the implants you can see?
Yes, sir. I can, this is a X-ray of the right leg and foot with ankle joint, showing AP and lateral view, showing both bones of the leg with the tibia, tibia and fibula, talus and calcaneus. We can see a undisplaced fracture at the junction of middle and lower 1/3 of tibia. and proximal displaced fibula fracture. Proximal 1/3 displaced fibula fracture.
Okay. What is the hardware that you can see?
This is a external fixator, unilateral and uniplanar with the 2 pins above and 2 pins below.
Anything else?
Okay, oh yeah.
K-wire is seen in the lower third of fibulas.
K-wire is there, no? Okay.
Middle and lower.
Correct. Yeah, that's
Yes,
what I mean, you have not mentioned this in the earlier when you were talking about your X-ray.
Yes, sir.
When you
They
were
were-
describing your X-ray, na, you have not mentioned about the implant in the fibula earlier. Yeah.
Yes, sir.
Thanks.
Yeah. Also, when you're giving your diagnosis, no, what is your diagnosis?
It's a post-traumatic compound defect over the medial aspect of junction of middle and lower 1/3 of right leg of 1 month duration with external fixator and KY institute should be there, sir. Without
Not
any
only
neuro.
that, you have to talk, you have not mentioned about the type of fractures, no?
Yes, sir.
We are not
Right.
dealing with only a soft tissue injury, no? We are dealing with the entire injury right now, isn't it?
Yes, sir.
So in your diagnosis, it
Yes.
has to include even the bony injuries, no?
Yes, sir. We'll do so.
Right?
Yes,
Also, I'll just go back to what Dr. Giri was asking earlier. In terms of management, no, you have seen your wound now. Okay. After 1 month, your patient has come to you. Patient is having a soft tissue defect. How long
Yes.
do you think you want to wait before you go ahead with your surgical plan? You're saying that you will do dressings, no? How long do you want to keep doing dressings?
Routinely, we do dressings till the granulation tissue is healthy and plasma culture sensitivity report should be negative. Routinely we'll send a repeat swab again in 5 days. So usually we give 5 days of IV antibiotics followed by repeat swab, and there shouldn't be any active pus discharge from the wound.
Looking
And
at this
the
wound, do
based
you
on
think that
the
this patient requires IV antibiotics and repeated, pus culture? Look, can you describe this skin, surrounding skin, and all those aspects of the ulcer?
These are looking healthy.
How does the skin look?
skin is edematous, sir, in the first picture, as we can see. Surrounding skin is edematous, but
Next
the
picture.
skins are sloping edges with granulation tissue and minimal slough is there over.
So, in other words, I'm trying to ask whether can you go ahead immediately with
Yes.
debridement and flap?
Yes.
Yes, sir.
You can, no? Okay.
Hmm.
Any other options, like you said, your first plan is to do a fasciocutaneous flap, correct? Can you
Yes,
show me
sir.
the planning once again?
Yes, sir. This is a picture, sir. Would you like a video? Or...
Yes,
Hmm,
please.
So.
Yes, sir. This is the axis of the posterior tibial artery. From 2 centimeters posterior to a line drawn from sorry, sir. From the tip of medial malleolus to the tibial condyle, 2 centimeters posterior and parallel to this line, we can mark the posterior tibial artery axis, and we could find perforators at 5 centimeters, 9 centimeters, and 15 centimeters above the tip of medial malleolus. So first we have marked the defect, and we have placed basically this is planning in reverse. First we have given, these are the steps. First we have placed a lint cloth over the defect. First we have placed the lint cloth over the defect, and then based on the 5 centimeters perforator, and then We have done planning in reverse on this vascular pedicle.
So when you
Just
Yeah.
yes.
Yes, yes,
Just interrupting here.
Yes, yes.
Which type of flap it is? You are planning, is it?
It is a perforator-based fasciocutaneous flap, sir.
No. I mean, if you talk about the geometry of the flap, rotation flap or transposition flap, which type of flap it is? You are running.
This is a transposition flap, sir.
So transposition flap. So what? I mean, you not mentioned about triangulation of the flap. Is it there?
Of the defect.
Or
How do you triangulize the defect?
for transposition flap, what is the most important thing?
We triangulate the defect, sir.
So why you again mimic a circular defect? Why not depict a triangular defect, which will be there finally after debridement? Is it there?
We have mentioned this as perforator plus flap, sir. So
That
that's
is
the reason.
perforator flap. Why you want to a perforator flap? It's just why not a simple inferiorly based transposition flap? Random better. 1:2 in the ratio of 2:1. See, one more thing that you will see that when you are transposing this, you are exposing the tendo Achilles. And if there is any infection is there, the tendo Achilles will be exposed, and suppose graft is lost and peritendon is no more there, then tendo Achilles will expose. Your work will be increased. Isn't so?
Sir, it is it will not be exposing a tendo Achilles, sir, because the posterior margin of the flap that is just 2 centimeter away from the axis, sir. So this is an axial pattern based flap. So we
No.
based it
Yes. Carry on.
axial pattern based flap. So we just using handheld Doppler, we mark the 5 centimeter perforator that is from the medial malleolus, and keeping that as base and planning in reverse, we gonna elevate the flap and gonna give the inset, sir. So keeping that in mind, so we will not be exposing the tendo Achilles, sir.
Okay. Tendo Achilles will not exposed because peritendon will be there. But if there is any, chance of infection that your graft get infected, then you may,
Yes,
create
sir.
a problem. Tendo Achilles will
Yes.
expose. So why not go to for a perforator flap based on 15 centimeter perforator? Just
15 centimeter perforator, we can.
take a 15 centimeter perforator and rotate it as a propeller flap.
Yes, sir, we can. That is also an option. We have ventured into it, and it is possible for a propeller flap based on the 15 centimeter perforator. That is also an option, sir. But
So your
and-
first choice is this one, perforator based, inferior based transposition flap.
routinely we do fasciocutaneous flap. That's the reason why we told it as first choice.
Yes,
But we can, propeller flap is possible based on the 15 centimeter perforator, sir. But we didn't.
Yeah, fine. You are more comfortable with it, so you will go with this,
Yes, sir.
right?
So this is a fasciocutaneous flap, you said, no?
Yes, sir.
So is there going to be a carrying segment in this over normal skin? Or what sort of inset are you going to have? Like, for example, your defect is a small circular defect over there, correct?
Yes.
And you're going to raise the flap in the shape of your pattern that you showed right now,
Yes, sir.
correct?
Yes, sir. We have taken 1 centimeter extra so that after development.
So
Can be given.
when you will triangulate the flap, your distal margin should be not rounded. It should be somewhere. Flap should be straight line.
So right now they have not triangularized. So okay,
Hmm.
we'll go with
Yeah.
that premise.
Right,
So,
right. Fine.
okay, you just sort of you're going to raise this flap and going to transpose it into that defect, correct?
Yes, sir.
Yes.
So will it have something like a carrying segment? What will happen to the secondary defect? You have not said anything about all that, no?
So for the secondary defect, we gonna place a graft over it, sir.
Okay. And will there be any intact skin?
No, sir. It's not interpolated flap. It's a peninsular flap that will be given insert over the defect after raising it.
Okay. And in your planning, no, have you made any allowance for turning of the flap? Like you have just sort of swung it as it is, rather than, you've not kept any sort of like even a minimal amount of folding space at the lower end of the flap, like a small
There is
dog ear types.
folding near the lower end, sir.
Yeah. Is there? See,
Yes, sir.
considerably when you're doing it on real tissues, no, you have to I'll make allowance for much more folding to happen, rather than a small, a piece of lint will not really, that much folding is very, very minimal what you have shown.
Yes, sir.
When you do planning in reverse, your flap has to go a little higher. There has to be more folding in your lint. Finally, to, from where the fold will, it'll allow the flap to fall in the correct place.
Okay, sir.
Yeah, yes.
Also, if you're going to do it by a transposition kind of this thing, your flap has to again come from a little higher. It can't be coming just adjacent to the defect, or just 1 centimeter higher than the defect is not sufficient for it to come into the defect.
Yes, sir.
Yeah, Likita, very basic question. We have discussed about the flap. Why do you require a flap for this defect? Just tell me the basic thing.
There is a exposed bone, fracture site is exposed.
But you
So-
said the epithelium is there is a sloping edge is there, na? Right? So sloping, what does it mean? Sloping edge means there is a healing epithelium, right?
Yes,
So it's
sir.
going to heal. Just keep doing the dressing. Why do you require a flap?
We are going to give a flap because of the exposed bones.
Exposed for the exposed bone.
Yeah.
Right.
Actually, fractured
Oh.
bone segments are displaced, sir. So external fixator has been applied only as a temporary measure by orthopedician. So after soft tissue coverage, so the secondary intervention will be done after removing the X-fix. So internal nailing can be done. So we want to have the stable soft tissue coverage first, so that orthopedicians can intervene further.
Okay. So a few things, a few suggestions that you didn't mention about the measurement. Whenever you discuss a case of leg defect, so you mention the measurement. That is very important. Second thing, the range of the motion also you didn't describe. So active and passive range of motion, both the ankle and the toes and the subtalar joint and for the knee joint, that also you need to mention, right?
Yes.
Second thing you told about that you will be using that inferiorly based hemisoleus flap, right? So what kind of muscle soleus is?
Type 2,
Is it type
according
5,
to Matheson, it's type 2.
type 2? And what does it mean?
It has a one major vascular pedicle and one minor pedicle.
What is how it is different from the type 5?
Type 5, the flap survives on the minor segmental pedicle if raised on minor segmental pedicle alone, if the major is sacrificed. But in type 2, it's not possible.
So how it is going to survive? It is type 2 now. So how it is going to survive based on the minor pedicles?
So based on the perforators, based on the blood supply that will be given from the positibial artery on right side, on medial soleus, and also left peroneal artery on the left soleus, sir.
What is the function of soleus?
Plantar flexions.
What else? Its use has been criticized because it contains numerous valves. So many people, they don't like to do it, right?
Sorry.
It helps in the venous return to the heart.
Calf, peripheral hearts.
Yeah. So another thing, the bone is exposed since for last 1 month, right? So the same patient comes to you in emergency. What is the right time when you plan for the flap cover?
If the bone is healthy and
There is no contamination, so we will go for a flap cover immediately, sir. Along with orthopedician, we will be doing the surgery immediately.
What is Godina principle? Have you heard about Marco Godina? What is Godina principle?
Sir, Godina principle, yeah, Godina says the compound defect should be covered using a free flap within 48 to 72 hours. And trauma, sir.
And what is Godina approach?
See, sir, Godino approach starts from the popliteal crease, that is exposing the popliteal artery and then dividing the two heads of gastrocnemius and tracing the vessel and going near the proximity of the defect and see whether the vessel is good or not. If in case if it is good and reliable, and the free flap anastomosis will be given the recipient, it will be anastomosed to the recipient vessel near the proximity of the defect cell. That is Godino's approach.
Did you talk about the sensory innervation of the foot?
Sensory,
Is it
distal
important?
sensation.
You have not mentioned
Presence.
sensory.
That is very much important whenever
Yeah.
you deal with a tibial fracture or leg fracture, right? Many times you will get the mangle extremity. So need to decide whether it can be salvaged or it be amputated. That is also important. So plantar sensitivity, you
Yes, sir.
examine in all the cases, right? How is the nerve
Yes,
supply
sir.
innervation? What is the innervation of the foot? Can you tell me the nerve supply? Sensory.
Sensations are present, sir.
No. How, from which nerve it supplies which area is supplied by which nerve?
Laterally by sural nerve and posteriorly by posterior.
There is a medial plantar nerve, a lateral plantar nerve.
Nerve and its branches. Deep peroneal nerve.
Which area is supplied by deep peroneal nerve?
Deep peroneal nerve. First web space.
Right. And what else?
Superficial peroneal nerve in the lateral aspect.
Superficial peroneal nerve, the sural nerve, right? And the lateral aspect. And the heel is supplied by the calcaneal nerve, right?
Right.
Yes.
Yes.
Okay.
Medial
So you
border
saw-
is supplied by?
Sir?
The medial border of the foot is supplied by?
Medial border, yeah, that is also left.
Plantar.
Medial border.
Medial border of the foot. Something that could be affected in your present defect.
Saphenous nerve.
Saphenous nerve.
Saphenous nerves.
Does your defect have a potential for arterial injury? Can any arterial injury happen in the kind of defect that you have?
If it goes more medially, it can, sir, but no, not really, sir.
What are your free flap options in case you really have to go for a free flap?
Since it is a small defect, we can go for gracilis muscle free flap, sir.
Okay. So what would be your recipient vessel in that case?
So recipient vessel, after doing a Doppler study, if anterior tibial artery and posterior tibial arteries both are good, we'll go for anterior tibial artery, sir.
Anterior tibial artery.
But your defect is more close to posterior tibial artery.
Your defect is medial, no?
But if we are anastomosing, we thought of posterior tibial, sir, but if we are anastomosing above the bone, then posterior tibial would be much deeper than anterior tibial. So we thought anterior tibial would be a better choice between the two.
So you'll cross across the anterior border of the tibia and anastomose to the opposite side of the
No.
tibia.
No, sir. In case if we want to anastomose with PTA, that will be, we'll have to go behind this lateral malleolus, medial malleolus. So that will be, it will be a retrograde flow will be there.
Why
Whereas,
medial malleolus? We are in the middle 1/3 of the leg, no?
yes, sir, yes.
So why are you talking about the medial malleolus right now?
No, sir, I was asking about the middle third.
I am asking what artery will you use as your recipient artery? Okay.
Yes,
And
sir.
you're saying that you're going to use anterior tibial artery. Your defect is on the anterior medial aspect of the leg. Why would you want to use anterior tibial artery is what I'm asking.
Okay. So
It is more accessible.
Sorry?
Um, Posterior tibial artery in middle third is not easily accessible. That's the reason why we thought anterior tibial is accessible between tibialis anterior and EHL. That's what we thought.
Why it's not easily accessible? It can be just where the posterior artery will lie. Just need to get a play and you will get it.
What sort of anastomosis would you like to do?
End to side anastomosis.
Okay.
Please show the picture, the defect picture.
Yes.
It's almost, I would almost categorize this as a like a lower 1/3 almost. It's not even like
Yes.
middle 1/3.
Which classification we usually used for tibial fracture? Lower limb trauma, which classification we mostly use?
Acute injuries, Gustilo-Anderson.
Sorry?
Tibial fracture.
Lower limb trauma, which classification?
Classification, which class? Sorry, asking.
Yeah, go ahead. You're just telling something, no?
Gustilo-Anderson classification.
Yes, Gustilo-Anderson.
Understood.
So according to that, which category this is?
Will come.
This is 3B, sir.
3B. So 3B, what it does mean?
It means fracture with more than 1 centimeter with devitalized tissue and bony periostal stripping might be there.
Might be there. You are already. It is there. So suppose you are after debridement, there is not seems to be periostal stripping there at present because there is a granulation tissue most of the part, right?
Yes,
so
yes,
you will go for debridement first of all before doing flap. So suppose there was a you're not able to see any periosteal strippings there, and once you debride, you see that there is no periosteum. So will you change your classification? And my question is, when you will classify a particular category at the time of your course in the
the time we receive the patient, we examine the wound. In acute setting, we grade it, sir.
Gustilo-Anderson classification.
Not after.
Your voice is not clear. When you will classify a wound according to Gustilo-Anderson classification? In
acute injuries, sir, not after debriding. In acute injuries,
as soon as the patient arrives in emergency department,
as soon as patient will arrive, he will not even let you touch the wound leg. And when the patient in an emergency come to you, the skin may be compromised, but not frankly necrosed. And due course, it will get necrosed. Then your classification will be changed. You will.
Yes, sir.
So then, when is it? I think.
Time.
Is it possible? Are you getting my question?
Yes, sir.
The acute setting, never the patient will not let you touch, not let you examine.
I can see some dead bone. What else? Yeah, what else you will get in the X-ray? You said that you will advise an X-ray. What else you will get? Just forget about this X-ray. Forget about this X-ray. So what else you can get if you advise a X-ray for any patients? Such kind of wound.
First, we'll see we can see whether there is the alignment is proper or not, and viability of the bone can also be assessed on X-ray.
How will you assess viability of the bone? What features you will get radiologically?
It will be more radio opaque.
More radio opaque. What is it called?
Opaque.
What is it called? What is sequestrum?
Sequestrum is a dead bone, dead non-viable bone.
What is difference between sequestrum and involucrum?
Sequestrum is new piece of bone.
Sequestrum.
Yes, tell.
I didn't get your question, sir. Sorry, sir.
What is the difference between sequestrum and involucrum?
Sequestrum is a dead bone, sir, whereas involution is a new forming bone on the side.
What else you will get? What is cloaca and what other features you will get in the case of chronic exposure of bone wound?
So periosteal reactions will be there, periosteal
Periosteal.
changes.
That is the first sign, right? What
Yes,
else?
sir.
Sir, sorry to interrupt. We have 10 more minutes. Sir.
Mhm.
Complete the discussion.
Actually,
Since we are talking about the bone, no? Can
Yes,
you
sir.
hear me?
Yes,
Yes, sir,
Yeah.
yes.
So since we are talking about the bone,
Hmm.
and this has been lying exposed for 1 month, what do you think are the possible sequelae of this kind of an injury? And how will you manage it?
Sir, possible sequelae, further infection may happen, and then there will be chance of osteomyelitis in future.
Osteomyelitis. Okay, what
Yes.
would be the end point of bony management in this case, in the present scenario?
Sir, bony management will be this after a soft tissue coverage, stable soft tissue coverage. The patient will be handed over to orthopedician because the bone is not aligned properly. So, considering this, the external fixator can be removed and internal nailing can be done once the infection settles. That gives that will be the proper treatment for the patient, sir.
Okay, after doing that, do you think that the matter will be settled once and for all?
No, sir. Still, the risk of infection will be there, sir. Whenever there is a open wound that is
So
not
what
proper.
happens? Like you're not telling me the final point. So what happens? So what happens? If there is an infection, so what happens? What will be the sequelae? What is the end point of that?
Sir, there can be
I can say the bone is dead. You need to tell what Dr. Venkat is asking.
dead bone.
But what will be the last
loss of bone.
Loss of
end
bone.
points?
I'll tell you the answer. We call it a non-union. Okay, there can be a
Non-union.
non-union.
Union also, yes.
So what happens if there is a non-union? Again, what is the end point? How are you going to manage a non-union?
Yes, sir. Non-union is when there is when the two bones are not united properly.
Correct. So how are you going to manage it?
Yes, sir. So patient will be handed over to orthopedician, and the treatment can be like in the cutting the end of the bones, pressuring the bones, and the using some amount of cement spacer, and then we can put a nail over it, and then we can treat in such a way, sir.
so what is mess?
You said you are going to put nail over an infection. How it is possible?
Sir, once infection is settled, so we're gonna treat the non-union part, sir. So the end part of the bone will be debrided or cut, and then here inside the nailing will be done, and outside on the bicortex we can place
How clinically you will see that the bone is alive or it is dead? Clinically, how will you determine?
Clinically, the bone will be lusterless if it is devoid of peritoneum, dirty yellow in color.
Yes. What else? During surgery, you need to debride you need to recreate the defect, right? You need to debride the wound. So during debridement, what else you will get? But not just going to put the flap over it, na?
Yes,
Yes,
sir.
sir.
You'll debride the wound.
There will be no bleeding point seen on drilling holes over the bone.
What is that called? When you drill or when you remove the
Paprika signs. If there is
paprika sign.
bleeding, the paprika sign is positive.
So you
So you said
debride.
you are going to put muscles flap over it, right?
Yes, sir.
And you need to intervene. You need to fix the fracture later on with a plate or something else. How you are going to cut the muscles and put the plate inside? Don't you think that a fasciculous flap will be better? Suppose if you are doing a free flap, so that's this you are going to use it.
I didn't get your question, sir.
What I mean that you told that you are going to do some intervention for the bone in the form of plating or something else. So if
Yes,
you are
sir.
going to put a free muscles flap in the form of grassleys, how you are going to go inside You need a facet clearance flap. That will be much easier, na?
Yes.
Right?
Fasciocutaneous flap is
Fasciocutaneous flap is
the better option. Option is
Can go inside the muscles also, but whenever you are planning some intervention in the future, it's better to use fasciocutaneous flap.
Yes, sir. Yes.
Yes.
Right?
In investigation, you mentioned Doppler,
Yes, sir.
color Doppler of the limb,
Yes, sir.
and you said that all pulses are present there, and you are planning a local flap. So still, will you? So why you want to go for Doppler?
Because the pulsations are present, it is not necessary that the vessel is patent or continuous in course and caliber, because there might be retrograde flow from the other arteries. As there are three main arteries in the leg, there might be pulsations present. So I would like to test for the course caliber.
You can
patency.
you can go for LS test. If
Um,
you are suspecting, you can go for Allen test. I mean,
Yes.
Doppler is more or less in free flap, where you see one to the nature of fight is biphasic flow or triphasic flow. More or less.
Yes.
So in this case, I mean, it is not that useful.
Okay, sir.
Okay.
Yes.
Very
Tell me
nice
about,
discussion. Dr. Giri, you please ask.
and last question I just want to ask. Tell me about what is MES? MES, MESS, MES.
Extremity
Severities, sir.
It has four components, and maximum
What are the
score of
components?
11.
What
And
are
if
the
it has
components? First,
Skeletal
what are the components? Say.
component and skeletal shock,
shock,
limb ischemia, and age.
How it is helpful in our daily activities?
if it is more than 7, if MES score is more than 7, we'll go for amputation.
It basically
do-
states we can go for amputation or we can salvage the limb.
Yes.
They-
Have you heard the term Ganga score? Anything regarding that one? Ganga score, Ganga has done. Ganga score is there, which is also helpful in that one. Have you heard?
GHOISS.
Hmm?
Ganga Hospital Injury Severity Scoring.
Have you heard it?
Have you heard of
We
that?
have, sir, but we don't know, sir. We are not aware of it.
The score is 0 to 29, and like this, if it is greater than a 14, then it is. There are a lot of things like skin and skin. If you take the skin and then bone and joint, they have separate criteria. Yeah. So the score is 0 to 29, and if it is more than a 14, then your amputation.
There is an app also you can see whenever a patient comes to emergency. Of course, you should remember it, but there's an app for the Ganga score. That. You said propeller flap, na? How do you define a suitable perforator? When do you call it a suitable perforator?
Definition of propeller flap, sir.
No, when do you call a perforator is suitable for
Suitable perforator.
attending a
Yes, sir,
flap?
we found a 15 centimeter perforator which was suitable for propeller.
How do you define the suitability? What I am asking?
Based on at least size or diameter of the perforator, sir. If it is more than 1.3 mm to 2 mm in diameter, it is good perforator. Based
The
on
perforator more than 0.8 is good enough. What else?
Yes, sir. And handheld Doppler, there will be adequate flow should be there.
What hertz of Doppler do you use for the hearing the sound of perforator?
What is the frequency?
What is the frequency of?
Set 10 hertz, 10 megahertz.
10 megahertz.
Yes.
Sure.
4 to 7 yard. 10.
superficial.
10 at
8 megahertz, if I'm not
Eight.
mistaken.
8 it is.
8.
So apart from the diameter, you also need to see whether the two vena comitatus are there along with the perforator, and it should have a
Right.
pulsation. Then only you should choose it, right?
Yes, sir.
Yeah. Other conditions you can ask.
And Dr. Umar, I think we can time.
Yeah, time is also need to stick with the time.
Okay, sir.
Voice is breaking actually.
Okay, sir.
Your voice is not clear, sir.
Clear, sir. And
Okay, sir. We'll move to the next part,
Now
like
it's okay.
questions from the other PG teams to the PGs who are presenting. Now I'd like to call PGs from Team 1, Madras Medical College. PGs from Madras Medical College, Team 1, do you have any questions to the presenting team? Okay, now Team 2, PGs from Jipmer Pondicherry. PGs from Jipmer Pondicherry.
Hello. Sir, yeah, my question is, what are the type of fixators you know?
external fixators and internal fixators. Internal fixators, you can use nailing or plating.
External fixators, they can be unilateral or bilateral, and which in turn can be uniplanar or biplanar.
Right. Thank you.
Now questions from Team 3, KGMC Lucknow. PG from KGMC Lucknow.
Hello. My question is, can you please tell me something about keystone flap and what are and can it be used it here?
Yeah, keystone flap can be used when there is a laxity. The subcutaneous tissue should be lax. And
defect should be elliptical. It is good if the defect is elliptical in shape and
on either side there will be a line drawn at 90 degree, and then the length to length ratio of flap and the defect can be up to like 2:1 to 5:1.
Can you please define it? Actually, it is a perforator based island flap, which is based on one or more perforators. And as you said, it can be used for adjacent defects. And it has to be elliptical. The defect has to be elliptical, but it may be used here. Thank you.
Yes. Thank you.
Okay, questions from Team 4, Stanley Medical College. PGs from Stanley Medical College.
Yeah, good evening. One of your flap planning was RSA flap. What is the most common complication of that flap?
So venous congestion is one of the most common complication of RSA.
Yes. Then what is the venous drainage of the flap?
Yeah, it is based on the drainage through the subcutaneous tissue.
And vena committents along vena committents or vessels and subdermal plexus also.
Yeah, partly correct. That is this sural nerve and lesser saphenous vein has saphenous, has its own artery, and that contains plexus venules. So it has its connection with this lesser saphenous vein, which bypass the body. So which is the main venous drainage for this flap. Yes, thank you.
Okay. Questions from Team 5, New Delhi.
Hi, can you tell me the mechanism of bone healing?
We didn't get you.
Mechanism of bone healing.
Acha, there are 3 phases are there. First is hemostasis, then formation of soft callus, then formation of hard callus, and then remodeling phase.
Stage of hematoma formation with inflammation, and then soft callus, then hard callus, and remodeling.
What is this whole process called? Like in other ways, can you tell the difference between osteoinduction, osteoconduction, and osteointegration?
Osteoinduction is through bone morphogenic protein, and
there is stimulation of bone osteoblast to produce a bone. That is osteoinduction, and osteoconduction can happen over any surface, whether of the implant or not. Yes, depends on it.
And osteointegration is when you use an implant.
Yes, osteointegration is anchorage of the implant. Yes.
Yes, thank you.
Yeah, thank you.
Questions from Team 6, Bangalore Medical College.
Good evening, everyone. My question is, what is the type of soleus flap, and what is the blood supply of soleus flap, soleus muscle flap?
Yes, sir.
It is a type 2 flap according to Matheson and High, and it has a superior, middle and inferior pedicle. And superior is supplied by popliteal artery. Middle can be through tibioperoneal or peroneal branches, and inferior pedicle is 50% is through posterior tibial artery and 50% with
Peroneal
peroneal.
artery. Yes.
Yeah, correct. Thank you.
Yeah, thank you.
Questions from Team 7, CMC Vellore. Do we have PGs from CMC Vellore? I don't think so. Next, Team 8, Safdarjung Hospital, New Delhi. PGs from Safdarjung Hospital.
Hello.
Hi.
Hello.
Yeah,
Hello.
hi.
Yeah. What is triphasic, biphasic, and monophasic flow and color Doppler? How these waves are formed, and what is their significance?
Biphasic and monophasic.
The
Biphasic is normal.
triphasic
Yes.
is normal.
Normal flow, and biphasic, monophasic is there is when velocity and flow is lesser than the
Peak
normal one.
Based on peak systolic velocity. We're not sure.
Yeah, we are not.
Okay, the triphasic flow has three waves that are formed by first form is formed by sharp systolic flow, followed by early diastolic flow reversal, and then the form by left diastolic return to anterior flow, and biphasic flow, that is a normal flow. And biphasic, hello.
Yes,
Yes,
we are
we
on.
can hear you.
Yeah, biphasic, there is absence of this early diastolic flow reversal, but it can be considered normal if there is a sharp systolic upflow, and it occurs in biphasic flow can occur in mild stenosis, and in severe stenosis there is monophasic flow, which has blunted antegrade systolic flow, which continues into the diastole.
Yes.
Okay.
Okay.
Thank you.
Now, questions from Team 9, RML Hospital. I think they are not there. Now, Team 11, Kilpauk Medical College. PGs from Kilpauk. Okay. Now, moving to Team 12, PGs from MAMC.
Hello.
Hi.
Can you tell me the blood supply of tibia?
The nutrient artery from anterior tibial
Where?
artery.
Yes.
Yes.
Yes, please.
Osteal and periosteal arteries.
Yes, which gives nutrient artery where the nutrient foramen lies, where it enters into tibia.
At around 7 to 10 centimeter from the tibial tuberosity.
No. Okay.
No. Yeah.
Okay, I'll take.
Yeah.
Okay. You said a nutrient artery and a periosteal vessel. Nutrient artery is from the posterior tibial artery, enters into the posterior tibial cortex, distal to the soleal line at the middle 1/3. Enters posterolaterally near the origin of soleus muscle. Artery will travel inside a 5.5 centimeter and divides into 3 branches. 3 ascending branches and a single descending branch. Okay. Then it provides the endosteal supply. Then the periosteal supply is given by the anterior tibial artery.
Okay.
Okay.
Yes.
Thank you.
Thank you.
Now, questions from Team 13, NIMS, Nizams, Hyderabad.
Hi.
Hi.
How do you handle the complication of venous congestion in reverse viral flap?
Limb elevation. First is limb elevation. Any suture, we'll remove the staples or suture, whatever we have applied. We'll remove the suture. Suture removal will be done, and we'll wait whether there is bleeding seen on the edge of the flap or not. And
If it is not settling with
adequate
hydration.
along with that.
What is supercharging of the flap?
Supercharging is adding venous drainage, matlab, increase the venous outflow by connecting to the another vein for the flap.
Okay, thanks.
Yeah, thank you.
Thank you.
Now questions from team 14, Ganga Hospital, Coimbatore. PGs from Ganga Hospital, Coimbatore.
Yeah. Good evening.
Hi, good
My question is, what is Kim-Lippert classification and what is its significance?
Sorry, we are not aware.
Okay, so basically it's a classification on the branching pattern, various branching patterns of the popliteal artery. So it is an idea about the classification helps in planning for the fasciocutaneous as well as in free flap, because type 3C according to this classification is the peronia magna.
Okay, thank you. Yeah, thank you.
Thank you.
I request team 15, PGs from AIMS Bhubaneswar. Do you have
Hello,
any?
good evening. Can you
Hi,
please
good evening.
describe the masculate technique? Masculate technique.
Yeah, masculine technique, basically when there is segmental bone loss and we feel that bone is dead, the after adequate debridement, we'll place a bone spacer on the bone loss segment and along with external fixator. So you have to wait for 4 to 6 weeks for the membrane to form. Once the membrane is formed, we'll put an incision and then we'll take out the bone spacer. Yeah, and then we have to do a vascularized bone graft or something. That is
Membrane will
yeah.
formed and will itself
They basically it is done for loss of segment in bone, any long bones like in tibia mainly.
Yes, so it's also called as induced membrane osteosynthesis. As you rightly said, it's for large segmental bone defects. First stage,
Yes.
as you described. The second
Yes.
stage, we remove the antibiotic spacer, which is sometimes a combination of PMMA cement with antibiotics, and we fill it with a corticocancellous graft or a combination of bone graft and bone substitute. Thank you.
Bone substrate. Yes.
Um,
Yes. Thank you.
The last team, teams Rishikesh, team 16, PGs from AIMS Rishikesh.
Hello, good evening.
Hi, good evening.
My question is, what is rule of third for lower limb extremity reconstruction? What is rule of third?
Sorry, we are not aware.
So it's like lower limb will be divided into three parts: upper, middle, and lower. As your presentation was based on middle third defect. So traditionally, for upper third defect, gastrocnemius flap was the ideal choice. For middle third, it was soleus flap, and for lower third, it was a free flap. So it is a low. It was called traditionally as rule of third. Thank
Okay.
you.
Is the standard matlab, what you asked is
No, it's
standard?
not standard. It was a traditional. Now it's all the personalized. Okay. Thank you.
Sorry, what is this rule of?
Third.
Rule of third.
Yes, sir.
Any questions from the delegates audience? Rohit, there are some
Sir,
questions.
I will move to the main part, sir, presentation part.
The question.
Hello.
Sound करके बंद करो.
Can I ask a question?
Yes, sir. Please, sir.
Yes. If you are called in emergency and the primary treatment is to be decided and applied, the orthopedic team is there and you are also there, the plastic surgery team. So suppose you are planning the same flap. So what will be the sequence of events? This is a very practical question
Yes,
I'm
sir.
asking you. So orthopedic team has to do their job, the primary, say internal fixation, and you have to give a flap.
Yes, sir.
So what
Sir,
will be the sequence?
after receiving the patient in casualty, so we do ATLS. By that, we do resuscitate the patient first, and then the bone will be stabilized first by orthopedic team. Along with that, after once it is done, when it is stabilized, after giving adequate wash and everything, and wound is good and clear, and then we can we'll go for this flap cover at the same time, sir.
I will modify your answer a little. See, two parts are there. One is the bony part, other is the flap. So if you allow the orthopedic surgeon to intervene first, what they do is they look for the bone straight away, and they damage the perforators all around.
Okay, sir.
Because they straight go to the periosteum, incise it, and dig up the bone and do their job. The correct method will be, as we have experienced, that you raise the flap first.
Okay, sir.
You tell them that don't disturb our perforators. We'll raise the flap, give you a better exposure than otherwise, and then you fix the bone, and then we suture the flap. So this should be the sequence. This is a practical thing which we all follow.
Okay, sir.
So can I just add one thing? I can't resist to. Bhattacharya sir.
Please.
Sir, yeah, I totally agree with you, sir, because what I feel, even debridement is very important. The success of your flap depends upon your debridement, and debridement has to be done by a plastic surgeon. So
Yeah.
whenever a patient comes to you, you debride the first, then you give the patient to the orthopedic surgeon, then you can do the flap cover, right? So even the most of the orthoplastic society, they have declared it that an open injury to the leg or an open fracture is a plastic surgery case, not an orthopedics.
Yeah.
If you take it first, you debride it nicely, then only your flap will be successfully, it will cover, it will enhance the bony union, right? So it is not like an orthopedic case or plastic case. So you take the lead and you do the debridement flap.
So you debride it, raise the flap, and give them the exposure, and then let them do whatever they want to do and suture the flap.
Okay, sir. Can we move to the next part of the presentation, though? I mean, session? Okay, sir. So we have 10 minutes for the spotter. You just see the spotter and.
Venkatesh can take the spotter.
Yeah, sure. Yeah, go ahead. Please describe what you see.
Here we can see a pressure sore over the sacral area. There's a grade 4 pressure sore.
It is grade.
Why do you say it's grade 4?
How the grading? Okay, can
What
you
is the
tell the
grading?
grading?
4 grade. It is divided
Yeah.
into grade 1, 2, 3, and 4. First, we have grade 1. It is non-blanchable erythema. In grade 2, it involves epidermis and dermis, and in grade 3, it enters the subcutaneous fat. In grade 4, muscles and the deeper structures are involved. I mean,
No,
they are
no,
exposed.
grade 3 is underlying muscles. Yeah. Grade 3 is underlying muscles and grade 4 is bone and joints. So you tell that this is grade 4.
We are not sure about the central part. We were not sure. But if it is only
In-
muscle, then
You are getting confused. There are two classifications, right? Can you tell me which classification you are telling? One is American Joint Committee Advisory for the Pressure Ulcer, and another is the SIHA classification.
SIHA classification. So which one you are telling? Normally we tell SIHA. So according to SIHA, whatever you are telling, just tell.
So what you're saying is okay, except for the fact that, probably you can't make out the real depth in the photograph.
In the
So,
second
yeah,
part,
it is okay to say that it is grade 3. Possibly, once you debride it, if the bone is exposed or something, it can be as deep as grade 4 also. So, yeah. So, what in a patient who's having a pressure, okay, now these are now called as pressure injuries. Okay, a patient is having a pressure injury. What is the risk scale called as? A patient who is at risk of developing a pressure injury, okay, there is a scale for knowing what is the risk. What is that scale named? Have you heard of Braden scale?
Braden,
Braden.
yes.
You heard
it
of
has-
Braden scale? Okay. Okay, how do you manage this patient?
We'll debride first we'll rule out whether the patient has any comorbidities and the reason for this pressure sore, and it will optimize the patient, and regarding the wound, we'll do thorough debridement and regular dressings, and based on the defect, can resurface the sore by flap covers.
Imagine that this patient is a patient of paraplegia since 9 months. Okay. What would be your
So
management?
first adequate nutrition, and then giving airbed and a
Change of
position
position every
for us, and then
second
for the
hourly.
wound we will do a regular dressings, and then we treat the wound by giving antibiotics also in case there is any infection, and
Any
then
particular dressings that you can think of?
sir, a bedsode, silver, biotin AG silver dressing can be made, or bedsode. There is a special kind of sacrum dressings are there, sir, specially designed for the sacrum, so we can use that.
We are using Metlex sacral dressing in our set.
Anything better than that you can think of?
Can we use NPWT, negative pressure wound therapy?
Yeah, negative back dressing can also be used.
That be a much better for this case.
Yes, please say negative pressure wound therapy.
Negative pressure.
Don't say VAC, right? What is the difference between VAC and negative pressure wound therapy? Very hard question. The same difference. What is the difference between photostat and Xerox? VAC is the company name, right?
Okay, sir.
So what you are going to do? Which flap? What?
Negative
Hmm.
pressure.
What is your plan?
I asked, what is your
One
plan?
thing
How
you
you
should
are going
also
to
know
reconstruct?
is the status of neurological recovery of the patient.
Yes.
How does neurological recovery affect your plan of management?
The patient.
Even after doing the surgery, if neurological recovery is not there, then patient will have a recurrent ulcer. Again, the bedsore will happen.
So
So
you
we
should not do any surgery for
Better
such
to
patient.
give a flap cover.
Okay, so for a patient who has poor neurological recovery, what you will do? For a patient who has good neurological recovery, what you will do?
For neurological recovery, we can we'll go for definitive flap covers.
What are your options?
Pilot.
Just be
What?
louder.
Biped.
Huh? What are the options in this case?
Options are bilateral VY flap.
Bipedical VY advancement flap we have done in one case. We're not sure.
Hmm? Okay, you are
What's Dr. Venkat is asking if you'll use which flap is better, fasciocutaneous flap or muscle flap? You only tell that you should answer. Then only understand. Which flap will be better for the pressure ulcer? Fasciocutaneous flap in the form of VY or rotation flap or a muscle flap with including the underlying gluteus maximus.
Not muscle.
It's infected, no? It is cavity, right? So you need some bulk, you need some padding,
So bulk
right?
normally we use muzzle flap, but myocutaneous, because muzzle flap, it again has to be researched.
So it is always infective. The muscles will deliver more antibiotic to the inside the cavity. It will decrease the infection. It will fill the bulk, right? Muscles will be better.
basically, what is the disadvantage between musculocutaneous and fasciocutaneous? Sorry, asking.
Yes. Then again, you can understand what sir is asking.
When bulk is needed, we'll go for musculocutaneous, and even though
It's a grade 4, no? You require bulk, require something to fill the cavity.
yes, there'll be no dead space in musculocutaneous, but with fasciocutaneous, we can't really cover the entire bulk. Bulk is needed, so in myocutaneous flap is preferred when bulk is needed.
What is the disadvantage of using muscles?
They need resurfacing with graft, and they can't be used when there is
No,
underlying.
you don't need to resurface with the graft. You can use the same VY or rotation.
Yeah, if we do a muscle, no, we'll do a musculocutaneous. You'll not do pure muscle over here. You'll do musculocutaneous.
Musculocutaneous one.
Musculocutaneous.
I was saying.
You are sacrificing the function of the muscles.
Yes.
Donor side.
Functional,
There is some
there will
good
be functional
recovery.
deformity.
Yeah, so if there is a good recovery, so you will be hampering the recovery of the muscles, though you are using the muscles also, right? So in those cases, either you use the VY or you use the rotation fasciocutaneous flap, or you can use the even kind of propeller or something, not propeller, but
So
kind of.
what sir is telling is, in case the patient is going to have neurological recovery, no, so don't
Neurological
compromise the
recovery.
muscle, don't compromise action of that muscle by using.
Yes, that is the answer.
Okay. Okay. So what is the other thing where a patient is having a good neurological recovery? So then what you will do? You already told that he's in a poor neurological recovery, you would like to give a flap option, correct? In a
Good
good neurological
recovery, we can try negative pressure wound therapy and see whether the wound improves, and
what is the frequency of offloading in this kind of patient?
we are not sure.
You know what is offloading, no? What I'm asking you understood, no?
Yes, sir. But frequency we are not sure.
Anything else, or shall we proceed?
Pathophysiology of pressure, sir, can you tell? Pathophysiology of pressure, the last question. Can you tell?
Yes, sir. When the bone is compressing the skin over the hard surface, if it is the pressure becomes more than 20 mm of mercury, the capillaries will get obliterated.
20 or 32, how much it is?
20 to 25.
30. Then after that, just go on fast. If there is increase in pressure, then what will happen?
So the skin necrosis will start happening, sir. Likewise, grade 1, starting from grade 1, it will, if the pressure is
There
not
will be friction. Then tell. And after that, there are 4 things. Just tell it. Go on.
Capillary injury will be there, microvascular injury, and then flow is impeded.
Then there will be searing. Then there will be moisturizing, and there will be ulceration. Okay. So what is the most common site of this pressure sore?
Sacrum and heel, sir.
No, Most common site I am asking. It is ischia tuberosity.
Ischium,
Yeah.
greater plantar
No, I am asking the common site of pressure source. What are the sites of pressure source?
Ischium is one,
Eh?
greater ischium, ischium. Ischium tuberosity, greater trochanter, sacrum, heel,
occipital region,
occipital
and the shoulder blades.
And malleolus. So most common site is ischial tuberosity, not sacrum. Yeah.
No, basically, just like in our Indian scenario, it is a sacrum, but in the Western countries, it is a ischium, which is more common. What is it in the book? So,
Okay, sir.
Thank you. Let us move to the next. Prakash Chandra sir, can take it.
Describe the condition.
Describe the X-ray.
Yes, sir. It's a X-ray AP view showing third and fourth finger bony fusion at the distal phalanx. Probably it's a case of syndactyly, sir.
What kind of syndactyly it is?
It is a complicated syndactyly, sir.
Complicated.
Complex.
What does it mean? What is it? What is the difference between complex and complicated?
Sir, in complex, there will be complex syndactyl, there will be a fusion of two bones. I mean, either on either side, adjacent distal phalanx or proximal phalanx or middle phalanx. Whereas in complicated syndactyl, there will be a transverse bone segment will be there, sir, and it will not be aligned properly.
Can you describe the X-ray again?
What is this? Sir, X-ray hand, AP view showing.
Is there only one hand or there are both hands?
Both hands.
Bilateral hands. Yes, both hands.
What do you see on one hand? What do you see on the other hand?
Yes.
Sir, one hand on left hand, we can see a fusion of distal phalanx of third and fourth finger. Whereas in right hand, there is a fusion of distal phalanx of third and fourth finger.
Distal and middle.
Middle phalanx, what is happening?
What about the middle phalanx?
Speak properly. Say properly.
They've even shown you another inset picture below.
Yes, I've seen it.
What is it? Absolutely.
Okay.
Okay.
How do you manage this?
Sir, if in case of complex syndactyly, so we have to separate the two fingers, and also we have to create a web space in between, sir. We have to plan.
Okay, keep talking.
Go on, tell him.
So the creation of web space should be there. So we have to plan in such a way like there should be a dorsal rectangular flap and then a mirror image zigzag till the tip of the finger. And
for real? For real?
Sir.
Can you sort of show how the markings will be? Can you like sort of show it on your finger? What are the points that you would like to mark?
Sir, here it will be like a dorsal rectangular flap on the 2/3.
At the junction of proximal 2/3
So
and
when you start marking, no, what will you start marking first? Will you straight away mark the dorsal rectangular flap, or what markings you will make? How will you start doing markings for a syndactyly?
What are the points? Sir is asking what are the points you will take and how will you start?
The metacarpophalangeal joints and IP joints will be marked, and from the in the proximal phalanx at the junction of proximal 2/3 and distal 1/3, we'll draw a rectangular flap and from one edge onto the other.
Mirror image zigzag incision.
Okay.
Incisions are marked over the IP joints and the mirror image is done on the volar side.
So do you involve the joints while marking?
No, sir, we will not involve the joints
But
because we have to
The
cover.
marking goes into the middle of the phalanx, no? When you put the marking, it
Yes,
goes
sir.
to the middle of the phalanx and finally to the tip. Correct?
Tip. Yes, sir.
Okay. And what are the other types of syndactyly that you're aware of?
Simple syndactyly
Simple can be complete or incomplete. Then
yes, sir, complete or incomplete, or surgical syndactyly. So is there, sir?
then you have told na complex, complicated.
Complex, complicated, then sir, yes. Other classification is other causes are surgical syndactyly.
Suppose you are separating the digits, the third wave space, right? The third one. And you get the distal bifurcation of the artery and the nerve, and you have to sacrifice one of the artery and one of the nerves. So which one you will preserve and which one you will sacrifice in this case? Which side you will preserve? Radial, ulnar, which side?
Did you get the question?
Yes, sir. We will try to preserve the radial border.
Radial border of what?
Of middle finger, sir.
Artery.
Yes, sir.
The third
Artery
one,
and
third one, you will get the
yes, sir, yes.
ulnar border of the middle finger. So you want to sacrifice the artery or nerve or on the ulnar side? You're operating on the ulnar side of the middle finger. Suppose on the volar side, if you see. Just try to touch your thumb with the middle finger. Which side you are touching?
Allah's.
You are touching on the radial side, no?
Radial side, yes, sir.
Sensation on the radial side will be more important, right?
Yes, sir, yes.
If you need to sacrifice the nerve, you can sacrifice on the ulnar side.
Ulnar side,
right?
yes.
What are the syndromes associated with this your syndactyly? Can you tell? Some of the syndromes are associated.
Yes, sir.
Apert syndrome, Pollard syndrome. Hard.
Yes, sir. Pollard syndrome, Bacterial.
Acha. Anyway, what is the timing of surgery of syndactyly? Whatever, sir. What is the timing?
Sir, in case of simple syndactyly, the timing of surgery will be between 6 to 12 months. And in case of complicated syndactyly, where there is a transverse bone bar, so we have to operate between 4 to 6 months to prevent the bone deformity or to correct the bone deformity.
Once you release the syndactyly, no? What sort of defects do you expect, or do you think that everything can be managed with just suturing?
Sir, there can be chance for web creeping.
No. I don't ask that. I'm asking what will you do? Will there be any residual raw areas after you finish your release and
Yes, sir,
suturing?
there can be, sir.
What are you going to do
There
about
can
that?
be. Sir, at the time of surgery, we can plan for either split thickness skin grafting or full thickness skin grafting. Full thickness skin grafting is more preferable, sir.
Why it is more preferred? Why it is more preferred? The full thickness skin graft.
Where is the donor?
Because secondary contracture will be lesser in full thickness skin graft, sir.
So you should
right.
So always use FTG rather STG, because it always.
We will use a full thickness.
We have used full thickness.
Full thickness.
Yes, full thickness.
Full thickness.
sir.
Which one will have more secondary contraction?
Sir, more secondary contraction will be there in split thickness skin grafting, sir.
How much percentage it is usually?
40%.
Yes, 41%, right? What are the
One
other
more.
advantages you take the FTSG?
Sir,
So what are the disadvantages of FTG other than this contracture? It does not grow with the body.
Yes.
So there will be repeated ulceration. So we continue with the question. What are the advantages of FTG as Dr. Rajmana sir said?
Secondary contracture is less. Repeat surgery is not.
Which one will have better color match, texture match?
Yes,
Try to
sir.
just tell.
FTG has better color match and texture, and also less chance for contraction, secondary contracture.
Which one will have better sensation?
Sir, a time limit has reached.
Yeah, we can move ahead to next one.
Last question. What is just one question? If the bilateral involvement is there, then what will you plan? What is the time of surgery? Bilateral involvement is there. What is the time of surgery?
Sir, we can do at the same sitting, sir. In case of simple, the same, it applies at, we'll be doing the surgery at 6 to 12 months, whereas in complicated one, we will do at 4 to 6 months at a single sitting, sir.
No, the answer would be like that one. If the age is less than 18 months, then you can do it when the child is dependent on mother. But if it is more than older, so you have to do one hand and the other hand after 6 months gap.
Yes,
Got
sir.
it? Chalo, next.
Describe the instruments you're seeing.
Describe.
Joseph's skin retractor outfits.
Skin hook.
Instruments, first instrument, the first one, the superior upper one, shows his Offrit's retractor. And the second one is Joseph's skin retractor, double hook skin retractor. And rest need or single hook retractor.
Where do you commonly use these instruments?
Sir, in case of rhinoplasty, we use these instruments, sir.
Okay, what rhinoplasty? You should complete your answer. An offrish is commonly used in what type of rhinoplasty?
Sir, in external rhinoplasty, sir, where it will be used to lift up the dorsum of the septum, which
It is open and closed. There is nothing like external.
Something called external rhinoplasty. It's open or closed. Okay.
closed. Yes.
What is the name of second instrument? Where it is used?
Sir, Joseph's skin retractor, that is also used in double hook skin retractor, that is also used in rhinoplasty to retract.
It is skin. It is cautelar nasal retractor.
Sir, ala, we can to retract the ala.
Yes. No. Just
What
to
sort
elevate
of-
the tip.
Sir.
Yes, continue, sir.
No,
It is
bolo,
not
bolo.
Joseph.
Yeah,
It is
yeah.
not Joseph double hook retractor. It is cautelar retractor, which is used in the rhinoplasty. Just elevate the this tip of the nose.
Yes, sir.
It is the third one.
Single hook retractor, sir.
Single hook retractor. Skin hook.
Single hook. Skin hook.
Huh?
Skin hook, sir.
Who described this as skin hook? You should know at least that is the question.
Yeah.
Who described this skin hook and what are the other instruments he described? The famous plastic surgeon all over the world.
Sir, Harold Gillies.
Yes. What are the other instruments? he
Sir,
described?
he devised an instrument that can hold the needle holder, and also at the same time it can used as cutting the thing also. And
Suppose if you don't have this instrument, if you are working in a remote area, so how will you retract the skin?
By applying a suture uh,
After
to
elevating
the skin, and it but that's also to the nearby skin, we'll apply the suture by the edge of the skin.
Yeah, that is the thing you can do.
Skin fish hook are also used for protection.
Yeah, fish hook is also there.
Okay, can you sort of tell us when you would like to do an open rhinoplasty, or what is the specific indications of open rhinoplasty?
Sir, dorsal hump.
Dorsal hump can be managed by closed rhinoplasty also. I'm asking you for specific indications of open rhinoplasty. What will be another instrument that you will be requiring in case you are talking about a dorsal hump, no? So for a dorsal hump reduction, what you would require?
Sir, osteotome.
Something simpler?
Or yeah. Rasp, nasal rasp. Yes, sir.
Yeah. So in case, okay, you're talking about a hump reduction. Suppose you want to do an augmentation. Okay, what are the modalities available? Somebody's got a depressed or a saddle nose. Okay.
Yes, sir.
So how will you sort of go ahead with what plan will you make for this patient? Or how will you counsel this patient regarding?
Sir, we can use, we have to counsel the patient. We have to ask the history first of all, and we have to ask the patient what she actually wants.
Forget the history aspect. I'm just telling what plan you will make for that patient for augmenting the dorsum of the nose. So what is your
Yes,
plan,
sir.
and what will you tell the patient?
Yes, sir. So we have to take a graft from either ear and we concha mainly to augment the septum of nose.
Anything else? What is the commonest?
Any other sites? Any other sites?
The commonest used site. If your requirement is very less, I can agree with your concha thing, but most of the times it is not very less. At least in India,
Yes, sir.
we require a lot of graft.
Coastal cartilage, any ribs, coastal cartilage can be used, sir.
Okay.
What are the coastal cartilage sites? Which one? Usually taken?
Sir, 11th floating ribs.
What is the commonest?
11th rib is not a part of coastal cartilage.
Yes, sir. Yes.
What is the complication that you can expect if you used undiced costal cartilage or a full segment costal cartilage? One of the complications that you can expect.
Inverted V deformity. Not sure, sir.
Have you seen any time harvesting of the coastal cartilages?
Not. Yes, sir. Coastal cartilage we have seen, but we have not seen rhinoplasty, sir.
No problem. No problem. Fine. Can we move on after instruments to the next?
Next.
You can
Make
see
the diagnosis and management.
This is here we can see a postburn contracture of right forearm and hand, right upper limb involving distal forearm, wrist, and hand.
Both hands are there, I think.
Sir?
Both hands are there, right and left.
Right hand.
Okay, it is right hand.
Dorsum and both.
Yeah, it's a single hand. Okay. Go ahead.
Different aspects. Yeah. Tell. What is the diagnosis?
Postburn contracture of right hand. Right forearm and hand, involving the wrist.
Is it just a contracture? There is a hypertrophic scar
Yes.
also.
Is it a contracture or
Hyperpigmentation
Clawing
with
Clawing.
with
deformity.
there is clawing is claw deformity of little finger, ring finger, and index finger. Yeah. Swannet deformity.
Why you are saying clawing
clawing
of the hand? Is it a clawing or something else?
Hyperextension on at MCPJ joint with the flexion at PIP joint is there, so that's why.
You need to
Not
unmute,
able
doctor.
to hear you.
Sorry, go finger to finger and talk about the deformities. It's easier that way, no? Just describe it as you see it.
You describe the whole thing.
Describe the entire thing, like, lower forearm, what do you see? Dorsum of the hand, what do you see? Each finger, what do you see?
What are you seeing in the forearm? Then
There
come
is
to each
in the
fingers.
forearm there is hypertrophic scarring over the dorsum of the hand and most of the volar aspect of the radial aspect of the forearms involving the wrist also, and there
Then
there is
thumb.
immature scar in the pinkish immature scar in the near the wrist.
And what about the ring finger?
Ring
Ring and second finger.
Squash, middle finger, sir. Middle finger swanneck deformed. Second finger is
So little and index.
Tell, go on. Tell me.
little and ring finger. There is hyperextension at MCP and flexion at PIP joint. Middle finger. It looks like not sure, sir, but it looks like swan neck deformity in one picture. And
Is there any dorsal contracture that you see? Is there any dorsal contracture scar at the base of the digits on the dorsum?
yes, yes, sir.
The hypopigmented area is there, no?
Hypopigmented area is there near the MCPJ joints.
Always in your description, no, always involve pigmentation also. When you say that there is a hypertrophic scar on the lower part of the forearm or distal forearm, say it's a hyperpigmented and hypertrophic scar. When you say distal to that, there is a hypopigmented scar, possibly causing a contracture on the dorsum of the hand, pulling up the fingers into various deformities. Okay. What is your management in this case?
Release and
Contracture release and resurfacing, sir.
Okay. How will you release this contracture?
Excisional release of the hypertrophic scar.
So
why there is hypertrophic scar? I mean, there must be raw area.
Sir, actually, we can see some meshings on the scarred area. So it could be the bone burn area that might have grafted, and then it got hypertrophic scar over the.
Yes, it was grafted and not post-operative rehabilitation was not taken care.
Taken, yes, sir. Now
So
we can.
that it was not apply advised pressure garment.
Yes, sir.
Physiotherapy. So the tendon stuck to the graft, and that leads to the secondary deformity.
Yes, sir.
Of the fingers.
So
now,
before
what you
planning,
do as
yes, Kala sir, bolo. I am asking you before planning any hand contracture release, what should be in your mind? What are the things you should think? Then you should plan. Because you are telling it is a contracture hypertrophic scar. So what should be the plan? So that I will go step by step.
So we should see the first sensations, joints.
Exactly. Skin, tendon, joints, all those things are involved
Joints.
or not.
And
Then
skin and supple joints should be there.
suppleness, yeah. Ligament capsule involvement. Then
Ligament capsule, yes, sir. We have
whether
to
the scar is mature or immature, whether it is blanched up or not.
then what covering is required, whether any skin graft or any flap, all those
Got
things
it.
should be in mind. Then you will go. Sir
Yes, sir.
asked, what is your management? So you should answer like that.
Okay.
And what are the donor sites available? The nearby things. Then you will plan like this. Then go on. Then for this case, what you will plan?
Sir, here after releasing, we should go for a flap cover. Any inferiorly based abdomen flap cover will be better for the patient because already contracture has happened. So that will be better option for the patient. And then after a flap settles, then we should give aggressive physiotherapy.
If the function of the limb is weak.
Do you think that it can be treated with conservative treatment? Maybe these are the joints are supple and we go pressure garment and proper physiotherapy.
So least likely, sir. Least likely. If maybe if joints are good enough and a patient is compliant enough, and then we can go for physiotherapy. But in case if it fails, then we should go for surgical treatment like flap cover after the release.
No. One patient comes to you, will you directly go for surgery or will see some conservative treatment like pressure
Yes, sir.
garment, physiotherapy?
Of course, till the surgery is planned, we should of course we should ask the patient, advise the patient to go for physiotherapy, and we should see the patient is compliant for the physiotherapy, and then if
This is right hand.
Suppose you have a surgical waiting list of almost 1.5 months. Okay. In the meanwhile, what can you do for this patient? Can you give something?
for physiotherapy and then splinting can be given, sir. Splinting acts. Yes.
Splints should be given to the patient.
Right.
Pressure garment should be given to the patient.
Given, yes.
Some silicone gel sheet, silicone sheet
Gel
you
sheet,
can apply.
yes, sir. Silicone gel sheet, yes, sir.
When
If
you
it is a
release this
recent
contracture,
Car massage, silicone gel sheet, yes, we can do.
when you release this contracture, okay, it is highly likely that patient will require a flap. Okay.
Yes.
Anything else that the patient will really require to keep the defect open, or rather for you to put a flap over there, or for the defect to remain as it is, or to keep the fingers in position, something else?
Sir, a K-wire should be applied in case we want to correct the finger and we have to keep it straight.
So when you talk about post-burn contracture, no, and when you're making a plan, like what
Yes,
Dr.
sir.
Giri was asking you that time, all these things should be mentioned in a flow. Okay.
Yes, sir.
That I would like to look for, donor areas. I expect that I'm going to get require a flap in this case, and I would like to, after releasing the contracture and putting the fingers in their, in the functional position, I would like to put K wires to maintain that position as well as maintain the defect before covering it with either a skin graft or a flap. Okay.
Which flap you will do? Abdominal.
Inferiorly based abdominal
Flap will be the better option for this patient, sir.
Why not groin flap? This is thin and pliable. Donor side is also primarily closed.
Again, you are going to put a scar over the abdomen. Suppose
Probably
she is a
should be
lady,
our
she has
first
to
choice
wear a
will be
sari.
groin flap.
There will be a scar. Put abdominal flap. There will be obviously a scar over the abdomen, na? A big
Yes, sir,
scar,
yes.
skin grafted area. Why you want to put the scar over it for the abdomen?
Because the dimension of the flap that will be required to for the correction will be bigger, sir. So I feel inferiorly based abdomen flap will be a better option for this patient.
Can't you do other thing?
Why do you say that the dimension of the flap required is going to be bigger? All
Sir,
this, are you going to do an incisional release or an excisional release?
Excision release for hypertrophic scars.
No. Sir is asking
mean,
whether you will go for incisional or excisional. For this case, whether you will go for incisional release or excisional release.
You know the difference, no?
Incisional release, sir.
The flap requirement will be lesser only. The size of the flap will be lesser only. If you just do the incisional release, right? You can do it with a groin flap.
Then we can go.
Your plan for excisional release, then you need to excise the volar aspect also. You need to excise all the scar and put the flap all over it, area.
So your primary concern is function in this case.
Function.
Isn't it? It's not cosmesis. So your idea should be to reduce the amount of flap required, reduce the amount of graft required, and try to get the fingers into a functional position which the patient can start using. Okay. So the idea should be to do an incisional release, bring the fingers down into the hand, and so your flap requirement is going to be less. So as Dr. Kala is telling, groin flap should be your first choice. Also, management of the secondary defect, it will change, no, between groin and abdominal flap. You can actually close the defect in a groin flap.
Primarily.
So can we move to the next part? I think time.
Yes.
What is this condition?
Here we can see middle-aged male with lesion involving the left side of the mandible.
What kind of lesion?
Malignant lesion, sir.
How can you define malignant? First, just by seeing the picture. It is not also obvious. Just say some growth, huh?
Yes, sir. Some lesion, some growth involving the mandible, left side of the mandible.
Mandible or GB?
Mandible or GB?
And
Gingivobuccal sulcus, not
lower gingivobuccal sulcus also.
Then
In fact,
there is
I can
ankylosing.
almost say, I think it's probably also involving the skin outside.
Induration over the skin is seen. Erythema and induration.
Fine, you can answer according to the questions.
you go on to it.
What are the causes for this condition? How will you prevent it?
Then second is what are the causes? Just go on.
The causes can be because of any pre-malignant lesions or smoking, any
Areca nut showing.
There was 6S that we used to read in the MBBS. 6S. Street smoking.
Yes, spirit smoking, syphilitic glossitis. Yeah.
Next, how will you prevent it? Go on accordingly. Your time is very less.
How will you prevent this condition?
How will you counseling?
Okay, assuming that it is a malignancy only, how will you counsel the patient?
First, we'll counsel the patient regarding the diagnosis, and he might require removal of the growth and probably mandible. He might require a hemimandibulectomy depending on the extent of the invasion to get a proper clear surgical margin. And he might require.
Imagine that, from what you're seeing in that image, you can imagine that it is involving the skin of the lip also. But how do you stage this condition?
Yeah, which stage it will be?
It would be stage 4. No, stage
Is 4.
3 or 4. Sir.
3 or 4. Can you tell me what is the
Why
Yeah.
3 or 4?
What is the 5-year survival rate for that stage 3 and 4?
30%.
Yeah. How do you define a 5-year survival rate? You have to plan your flap and everything according to that only, right? How do you define a 5-year survival rate? What it is?
We are not.
What are the options for this condition?
There is this slide is for operative and counseling. So before doing anything, you have to counsel the patients. So this is the primary aim of this slide. What you are going to counsel this patient, because patient doesn't know. So you have to properly tell them what is the diagnosis
mortality rate, what is the
after
cure
post
rate?
of what he is going to suffer. So all these things has to be told. So this is why this slide has been done, counseling. So how will you counsel the patients?
First, I'll counsel the patient regarding the diagnosis and the additional treatment or the neoadjuvant treatment. If considering it as a malignancy, he might require neoadjuvant treatment also for downstaging the disease. And after the what are the different surgical options he's having, and the extent of dissection that has to be explained, and the morbidity after removing the lesion, mandible, and how we are going to reconstruct, and from where we'll be taking the graft, I mean bone graft. For example, fibula, for that also donor site morbidity has to be explained.
The
No,
chances
you
of
have to tell him that his social lifestyle will be changed because he cannot take normal things. He has to take all those things. Patient has to properly explain. Patient must be thinking he will be fine after surgery or anything. So you have to tell that we are going to take the fibula. We will make this reconstruct mandible, whatever it, and after that again this radiotherapy, everything this has to be told. This is the proper
Radiotherapy,
protocol.
recurrence, all those things you have to mention to the patient.
All these things has to be counseling. That is why this slide is there. Next, what are the options for these conditions?
I'll just give you quickly 2 scenarios, very quickly. Okay.
Yeah.
Two scenarios. One is the tumor is just abutting the mandible. Other is that it is involving the mandible. Okay. So in both these scenarios, what is your operative plan?
Just abutting the mandible, we can go for marginal mandibulectomy, sir.
Okay.
If it is in the second scenario, it might require hemimandibulectomy or segmental mandibulectomy, depending on the extent.
Okay. So what is the deciding factor between these two? How will you differentiate these two?
Outer table of the mandible.
What is the diagnostic investigation that you will use?
Diagnostic.
See, based on CT with puff cheek.
Just do a CT scan, okay? And what is the finding that you will be looking for on the CT scan?
Whether there is any, we'll see the lining of the mandible and whether there is any gap between in the GB sulcus.
So in case of bony involvement, there we can see the periosteal reaction or involvement of tumor on the bone, and the extent of the bone can
Okay,
be.
go ahead with the stepwise operative management plan.
Okay, if it first I'll stage the first I'll do a biopsy.
No, you're in the OT now.
Okay.
Stepwise operative management plan.
Okay. We will go with hemimandibulectomy, and if lymph nodes are positive, we'll go forward with neck dissection and plan for a prefibula graft. Reconstruction with fibula graft.
Not graft, flap.
Flap, sir.
What is the options for recipient tissues?
This will be for your lining, or here what will be the defect? supposing in this case, what will be your defect?
What kind of defect you suspect? Whether it will be only bone
After
flap that
excision,
you are
what
going
kind
to
of
put
defect?
bone. Yeah.
You'll have a composite
Along with
defect,
soft
no?
tissue.
Yeah.
Huh?
Bone along with soft tissues.
Soft tissue, where? Where are the soft tissues?
What soft
Sir.
tissue?
Yes,
How
sir.
and how much bone?
Hmm.
How
Seeing
much
this
mucosa,
picture,
mucosa, bone, and then outer skin.
Skin, yes, sir.
Outer skin over
yeah,
the
that you have to tell. Mucosa, inner lining mucosa, bone, and also outer skin.
Skin,
So in
yes.
this case, how will you plan pre-fibula? Because next question is your what is your stepwise operative management plan? If you have planned for that one, how will you cover the lining, bone, and as well as outer skin?
The outer skin is going to go right up to the angle of the
Yeah,
commissure. Okay, he's going to
commissure
use this
also.
commissure. So now tell, fatafat.
PMMC and DB बोला था ना.
Mhm.
For mucosa, we can go with PMMC, and for bone reconstruction pre-fibula, and outer soft tissue.
Only one flap you should do.
So you are going to use 3 flaps. Is it?
Cannot single flap do.
Only one flap you have to use. That's it.
Hmm.
See, once you put the PMMC in the neck, then where will anastomose the bone, this fibula?
Okay, so if you want to do a PMMC, no, it's not
PMMC.
entirely a wrong answer. If you want to do a PMMC, how will you do the PMMC? What sort of paddle will you like to use?
Bipaddle we can do, sir. I mean, for inner lining and outer.
Okay, you'll do a bipaddle PMMC.
Bipaddle.
So ideally speaking, if you have the capacity to do a micro flap, your first choice should be or to always give a bony reconstruction. So a prefibula osteocutaneous flap should be your first answer. Okay. And a PMMC should be a salvage option.
Okay, sir.
What would you do to manage the oral commissure and continence?
Like that.
It's normal.
So let's go to post-operative care and follow-up.
Post-operative care, he'll be on right strip feeding initially, and
What is your protocol for monitoring of flap? You have done the flap, you need to monitor nothing. Monitor the flap.
monitoring of flap, sir.
Of course. You have done the flap, then you have
Don't want to monitor.
Free flap.
Yes.
Sir, one. I will
We'll
monitor
monitor
the
the, first we'll check for hydration and subdermal bleeding on scoring.
Scoring, do you
Warmth
score
of
it?
the flap, first we'll check for the warmth of the flap, and if there is any.
How will you
we'll check
monitor the
type
flap?
of bleeding on scoring, sir. If it is depending on the color of the bleed, whether there is
Just
any
need to see the it is a bright red bleeding or dark red bleeding,
bright
right?
red or dark red.
By scratching. Just don't need to score the things.
Score,
Understood, no?
Scratching.
Suppose there is a dark red bleeding in the night. You did the flap, you finish by 6 o'clock, 12 o'clock, you get the dark red bleeding. What will you do?
What may be the cause? First of all, if there is
Venous
dark
What
bleed.
is the cause?
Congestion.
venous congestion due to microthrombi or any thrombosis. Venous congestion would be your first doubt.
Suppose there is a no bleeding, then what will you do? What is the cause?
Then artery.
Huh? Then
what are the feature of venous occlusion and artery occlusion? I will differentiate. Either there is a
There will be
venous
dark red slow bleed in venous congestion, sir.
slow bleed.
Dark brisky, sir.
Risky, sir. Sorry.
And in arterial,
In arterial, should be bright red.
in arterial, there will be no bleeding.
No bleed.
or delayed, very delayed bleeding.
Ah.
Delayed bleeding,
Or
very
very
delayed bleeding.
delayed.
Very delayed video.
and coded flap.
Then what will you do? Yes, sir is asking.
Yeah,
In
yeah, what will
midnight,
you
if
do?
you see, what will you do?
Immediate exploration is a
Immediate
better option,
exploration.
sir.
With exploration, right?
The only option. There is no other option. You have to explore immediately.
Fluid
Yeah.
hydration status.
Improving hydration status and normally.
Sir, can we move to the next
Yes.
part?
Document this. Document.
How will you document this case?
How to document?
Yes, sir. Once the patient arrives to the hospital, we have to make it as an MLC first of all, and then we have to start recording the history about what happened and whether there is accidental, suicidal, or homicidal, and how it happened, and at the what time and at what place, and whether patient has been taken to any other hospital before coming here, and any treatment has been taken outside. And we should also ask his other histories, like in case it looks like electrical burn, so we should also ask whether patient had any history of head injury, loss of consciousness, seizures, vomiting, or any history of chest or abdomen injury and spine injury. Spine injury we should ask, and then we should also ask about personal history, past history, family history, and then we have to document properly about these conditions. And a local examination, we should clearly mention about the injury status or external marks injuries, and
We'll do an ECG.
yes, sir. And we have to document.
We'll do an electrocardiogram and
No, they've asked all the aspects related to this condition. Okay, we are talking about this particular condition. What is this condition that you see?
What is this condition?
Sir, it looks like direct contact electrical burns over the face, as the picture shows.
No, why you are saying direct contact one?
Sir, the left side of the face, it's completely there is a full thickness burns, that is because of direct contact.
Which direct contact with the which electric
probably
item you think that which just touch to the face and whole face is burns. It mostly is a high tension wire that gives you impression if it is a contact
high tension wire. High tension wire.
But it is not.
Contact
It is,
one, yes.
but it is not seems to be here.
Patient is also intubated. So if you see, what do you
Yes,
think?
sir, yes. As it has involved on the face, so there is chance for more edema all over the face, and also in the laryngeal edema anticipated. So that's why they have placed a patient on a patient is intubated to secure the airway first of all.
What sort of injury are we talking about?
Sir is asking what sort of injuries.
Which
What
type
is
of
the
burn?
injury that you will suspect and document in this condition? You want to document, no, the patient is having injury to the face in certain part of the face involving the nose. So what injury you want to suspect?
vision, there will be loss of vision and complete left half of the faces and so.
Vision is fine. We are talking
Vision.
about intubation, no?
Yes, sir.
So you have to document that there are injuries to the external part of the respiratory apparatus. So there is possibility of inhalational injury.
Involving nose.
We are talking about inhalational injury.
Yes, sir.
Loss of hair suit.
Then what are the other things you will document it? Just tell, because if you see the right part of the face has gone, whatever you see, then what are the things you have to document? Very carefully see. Eye.
Yes, sir. Vision.
Maybe his vision, her vision is, his or her vision would have been gone. That thing, everything, that opthal part, then face, nose.
Nose is also.
Then
Ear.
Also, you have to document the degree of burns of each part of the face which is injured, because every part that is injured has got a slightly different degree of burn. The management is changing in all the parts, no?
Yes.
Yes, sir.
So you have to counsel, for example, you have to document and counsel also accordingly, no? In surgery, what you will excise, what you will leave, what reconstruction they will require. So how will
Always
you
try to make
document
a
it?
diagram. Whenever you document, make a diagram and then you color it.
We'll mark it, sir.
Very
Mark it.
important. Yeah.
So tell us about this condition, no? Tell us about the degrees of burns that you can see in all these in the face.
Sir, on the left-hand side, on the scalp region and eye region, and also the cheek, and also on the lower middle and lower part of face, it's completely full thickness burns is seen, sir. It's a dark leathery skin appearance. And on the whereas on the right-hand side, we can see the right-hand side.
The left-hand side is not complete. In fact, you have still there are still areas, no?
Involving the
Acha.
cheek and ear. This is
Yes.
superficial
Be
partial.
thorough in whatever you're saying, no? Be thorough.
Yes, sir. On the left-hand side, frontotemporal region, we can see deep partial thickness burns, and also near the preauricular region, deep partial thickness burns, and also in the ear, superficial to deep partial thickness burns. Whereas on the mandibular region, again, a deep partial to
Deep partial.
deep partial thickness burns we can see, sir.
Okay.
Right side.
What is vitreolis?
Hmm?
Vitreolis. What is vitreolis? Have you ever heard about vitreolis?
Sir,
Yes,
yes.
sir. Throwing of
So
Acid.
can
base.
it be a case of vitreolis?
It can.
Sir,
Thought of better most. Yes, sir. It can be. Sir.
I'm not sure.
Can it be vitreolis, sir, is asking?
Yes, sir. It can be.
Okay. What is that? What is vitreolis?
So throwing of an acid is
Strong
usually
acid over
strong acid over face is vitreolis. So
In-
usually sulfuric
with,
acid
with an intention?
with an
What is the
intention.
intent? What is the intention of in the mind of the culprit to disfigure the face?
To disfigure the face, homicidal process. Disfigurement.
It's not homicidal. Basically, it's a
It's
male,
a
so
disfigurement
the
case
chances is
using
less.
an acid, strong acid
But-
over
Strong acid.
Which acid?
Sulfuric acid.
Sulfuric acid. So it may be a vitreous case, though
Yes.
it can mostly in the female just to revenge, just to not to kill, not the intention to kill the patient, but to disfigure the face. So it is more in female, but it may be a case of vitreolis because the type of burn, it is looks like a acid burn. You will see thick scar is there.
Yes, sir. Yes, we can see.
But I think it is not. Vitreolis do it.
What differentiate how it will be differentiate from vitreolis? Why it is not vitreolis?
Electrical one, why it is vitreolis?
Whenever you throw a liquid over a face, what will happen? What features? Wherever the liquid will drop down, it will have the same kind of burn, right? Isn't it?
Yes, sir. But chemical burns usually they take time to demarcate.
I'm not asking about
So
demarcation. I'm asking about the injuries,
I was asking about the pattern.
pattern of the.
Sorry, saying why it is not vitreolis?
Sir, there is no such things like splash kind of things are there. So, and it is moreover, it's look like a deep direct contact electrical burns. I'm not sure about
Right.
it.
Not saying you are not right, but you have to justify why it is.
it wouldn't be a deep full thickness burn initially on the
Electric burns are usually a flash burn that these linemen have while they are working on the high tension wire. So in that case, it is a flash burn over the face, but it may be frankly flame burn. That may be possible.
So sorry to interrupt. I think
Yeah, we can.
I think we can wrap up the session here. It's like final. It's like the panelist remarks regarding the PG's performance and suggestions for their improvement in their presentations and any note, and final opinions about the Plastiquest. First, I would like to request Dr. Sanjay Kumar Giri sir to give his valuable feedbacks.
Hello, Rohit.
Sir.
Rohit,
Question
can you hear me?
Sir.
Yes.
Before they comment, can I have a little space to talk about 2-3 minutes?
Sure, sir. Anytime, sir.
Thank you so much. Please.
You are muted, sir. Yes. Muted, sir. You are muted, sir.
1 minute, sir. I will unmute, sir. I think. I'm fine.
Can you hear me?
Yes, sir. Yes, sir.
Yeah, thank you so much. In fact, I will take only 3-4 minutes to comment as a faculty, not as an anything else. Okay. Regarding the first case, the Gandhi Memorial College, Gandhi Medical College and Hospital, Hyderabad, Dr. Naveen and Dr. Litika. Well, I have not comment on what you have spoke about, but some of the things you have left behind. That is it is a short 10 minutes. I understand very much, but there are very important things while taking a post-traumatic defect case. You ought to know about the detail of the history, at least the mechanism of injuries. It is a high velocity or low velocity. Then the GCS, consciousness, patients were on alcoholic effect or not. All these are small things, but that makes a lot of difference in recording on your planning for the future of the patient treatment as a whole. And the planning in reverse, what you have sold, you have never been told about the apparent defect and also the true defects. So that has to be done in a 3-dimensional way. What is the dimension that a defect is there, and what is your planning in reverse you are going to do it. So while doing all this, I understand the time factor is there here, but while you are a second year, you will be third year next year. So I think you have a sufficient time you can recollect, and what I am speaking and observing can be taken into your consideration on finding out this. And especially on the diagnosis, has been mentioned one of the senior faculties here also from the panel, that your classification on Anderson-Costello has to be made out there. And the period how much the patient has come to you, regarding the x-rays and all that in detail, I don't want to go in detail about it. But on the pressure source, it is not just what you see. There is a lot of things inside which you cannot see. What you are seeing is the tip of the iceberg. So about the bone, bursas, and all that details you have to go, because this is a competition. You are not given everything in detail. So while answering what I mean to say, you must also tell what are the factors also involved in this. So once you know that detail in investigation or your examination, your planning will be more appropriate. But however, tentative planning, you can give it as you have already been given. Same thing with x-rays about the bone. When the bone exposed is there, you have to have an additional flap that has to be put on that syndactyl case. So instrument, rightly, even you know Gillies hook, but what are the contribution of Gillies, these things has to be known, because there are different type of examiners. All examiners have their own way of asking you. So, and regarding the costal cartilage, one of the panelists has asked you. So you have seen it, but you have not marked what are the cartilage, is it 7th or 8th or 9th, it is a costochondral cartilage, all that. I think you have to be very thorough about it. There should not be confusion about a floating rib and a costochondral cartilage you are taking off. Then on the PBC, the maturity of the hypertrophic scar is very, very important, because it has its implication. That you should have also gone through. And always the reconstructive procedure have two things to be, basically form and function. And in that hand case, it is not just the form or the aesthetic part, but the function has already been mentioned. That has to be taken as a priority of your reconstructions. So this is an acquired postbone syndactyly. So obviously, already one of the panelists have already pointed out how physiotherapy is planted and all joints suffering, all these things has to be made within the time period. And your planning should be right from seeing a patient up to the future or the follow-up matters. So carcinoma cheek, that case was shown. So the particular question of particular case has to be dealt with, not everything. If you do not know about the detail of intraoral examination or the mandible involvement, you can opt for, yes, this investigation can reveal me this. If it comes to in this, then I can go for that. So last not the least, the electric burn. Well, there is nothing called deep partial burn. It is either superficial or deep, or you can mention the deep burns in a second degree deep, or is a third degree or fourth degree. So you have to be very specific in that. And already one of the panelists have rightly told, is a high voltage more than 11,000 kV or it is less than that? And what is the entry of the injury and exit of the wound? That is very important to record. Otherwise, how can you tell it is electrical injuries? So these are, and associated injuries, there may be a fracture if he's walking on the pole and fall down. Those are to mention, and eye and other things, how they have been, or eyebrows, if they have been involved, these are to be mentioned in the documentations of these patients. So I think these are a few things I thought as a faculty, I must tell you for your preparation for the final examination. Thank you very much.
Thank you so
Thank
much,
you, sir.
sir.
Thank you.
Thank you, sir.
Any other faculty who want to give their feedbacks
Yeah.
or inputs? Apart from the panelists, sir. Next, I will allow the panelists. Bhattacharya, sir, you want to give any final?
Yeah, right.
Okay, sir.
Regarding Plastiquest, I will first tell because it's a very good platform, and I must congratulate Lakshmi Madam, Rohit, Likhita, and Umar Baba and Venkat sir for organizing this type of things. And by this Zoom, you can have a different opinion, and you can also practice before your exam. So it's a very good platform for the postgraduate students. And during our times, there was one plastic, what was happening in Amrita, Plast at 2012-15. People were traveling there and going there for this practice 2-3 days they are staying and practice. But it is now, Madam has made this Zoom platform. Even if you are staying in your hospital, you can practice for these postgraduate students and without losing money. And yeah, we are not able to do at that time. Very few people are able to join in Amrita. That time it was being done. I am talking about 10-12. So it's Lakshmi Madam and their team, really thankful to them for making this type of event and making these postgraduate students practice there before exam giving, because it's totally like an exam. So, and about your parts, I will say that as you people are second year, I think you will go gradually. You have to little bit of thorough about your history, and you have answered a lot of questions, but still then like history, as Sarah has told, some of the parts has to be told properly. And whatever has been asked in your things like counseling, so go step by step. That this has to be particular about that one. Whatever. Otherwise, you people have answered a lot of questions. So if you have not known anything, just sir, I do not know, you just go on. So that you will not buy your time. You go on the next step. Otherwise, what we are waiting for your answer. So as many as questions we will ask you, we will answer. Maybe this question you may not answer, the other question you may answer. So just go on. That thing I will tell, and I hope you will improve, because you people are second year. So third year, I think you people can improve. As Sarah has already marked out in every parts what was the lacunas. So hope for all the best.
Thank you, sir.
Thanks. Now I would like to request Rajkumar Manas, sir, to just give his valuable feedback.
Yeah, I think both the participants, Naveen and Likita, they did very well, because just coming and answering to the 4 examiner just to online, it is it requires a lot of guts. So many congratulations to you, and you have prepared very well. Only thing what I don't like, that when you plan for planning in reverse, don't do with that OPT things that you use. Always use lint, because we were attend with using lint, so always use lint only. Don't use that OPT clause to cut it and doing the planning in reverse. So that is the one thing I would like to say. But I scold my residents also. You have to use lint only, right? Second thing, that movement and measurement. Whenever you plan a leg defect, inspection, palpation, everybody says, but nobody talks about the movement and the measurement. That is also equally important as this thing, inspection and palpation. Whenever you plan for the option, there are 2 things: reconstructive ladder and reconstructive triangle. Suppose you have to go to the first floor, either you can use a staircase or you can use lift, right? But suppose you have to go on the 7th floor, it's better to use a lift. Okay. So keeping the things in the mind, like form, safety, and function, you have to choose the option accordingly. Okay. Suppose you have to choose some complicated things, you can say the free flap as the first option. Suppose you have to go at on the first floor itself, suppose it's a smaller defect, can do a small transposition flap. That is a good enough. So you both did very well. And regarding Plastiquest, this is the third time I'm attending, and I must congratulate everyone, whoever is involved, Madam Lakshmi Madam, Rohit, Likita, Farooq sir, Umar Farooq sir, Sandeep Vijay Raghavan sir, everyone, whoever were involved. Even it's very nice to see Bhattacharya sir and Arun Chaudhary sir all the time. So it's always great learning joining this platform. So in the beginning, what I was talking, that one person asked the question and two persons learned. So even I learned a lot of things from you. Thank you guys. Really a great job.
Sir, thanks a lot, sir.
Thanks so much. Now, I request Prakash Chandragala.
First of all, thanks to organizer of Plastiquest, Madam and all, Farooq sir, a senior faculty here, and my thanks to my fellow colleagues. And you guys, you did good, but there is a lot of way to, there is more, long way to go. Since it's, you have one time, you're not supposed to answer each and every question, but yes, most of the questions you should answer, right? And I say history was not in detail because you given the less time, but definitely it should be more elaborative, because since you given 10 minutes, then you did very nice. And basically, you should learn. You start better to, I mean, in the department, start the group discussion. I mean, with the seniors, that will help a lot to you. Because the most of the time, the cases remain similar, questions remain similar. So with the time, when you will incorporate yourself with these type of programs, you will be more free, I mean, used to for the question and these questions. So far, a long way to go, but both you did good. And this guy is sleeping, I think. Okay, all the best.
Thank you, sir.
Yeah.
I request Venkateshwar.
Yeah, so Likita and Naveen did a great job. I think it's like what Dr. Raj was telling. It's a very challenging thing to, you know, present your case in a short time in the front of national faculty, you know, and expect to get everything right. So, and you guys are still, you know, you're still in your learning phase. In fact, I think we even we get a lot of answers wrong, and there are a lot of things that I learned from the other teams who were asking you questions. They had their questions prepared for you. So yeah, so take heart. I think in the fact that, you know, you perform quite well in all the sections. Yeah, surely you know, you can tighten up basics a bit. And remember that, you know, you have to, all answers have to be given in a very orderly and sequential manner.
Yes, sir.
Okay. Don't be haphazard in your answering. Be very thorough. Describe all the basic things, like what you see. All the answers are already there in front of you, what you're seeing, no? If you just describe everything in a sequential manner and, you know, have an orderly way of describing things, you know, most of the job is done. After that, what you have to answer next is only the higher level questions, which are like, you know, which by chance, if you're not able to answer also, you would have come through with passing marks as it is. So I think as a exercise, I think Plastiquest is a super success. You know, it is an amazing tool for PGs to you know, hone their skills for the upcoming exams. And I congratulate the entire team of Plastiquest for you know, this superb initiative. Hats off to Lakshmi ma'am, like a lot of effort she's taking and coordinating a lot of things, getting together a lot of faculty. And respects to Bhattacharya sir for taking out time on a weekday in the evening. And to all my you know, other panelists who have also joined today and given us their time. And thank you to Arun Kumar Chaudhary sir for giving such proper tips. In each case, he has highlighted what you should have, you know, what you have missed. And thank you also to Umar Farooq Baba sir. Um, I think I'd like to conclude my remarks over here. And once again, all the best for for the future to both Likita and Naveen. You guys will do well. Yeah, all the best to you.
Now I'd like to invite Bhattacharya sir to give his final input.
Thank you, dear. First, I'd like to tell the postgraduates what not to say and what not to do in exam. First of all, don't say we can try. We are talking of a particular case. And don't say in this case repeatedly. Or other thing is, the trick is that answer very precisely what you have been asked. Why? Because suppose examiner has asked you a question and you have answered already and you are going beyond it. Don't do that. Wait for the next question. Maybe he is going to ask you the next question whose answer you have already elaborating in the previous question. So you try to get more marks by answering precisely. Don't over answer. Your diagnosis should be very precise. That impresses the examiner. For example, in syndactyly, you should have said it's congenital, bilateral, complete, complicated syndactyly involving middle and ring finger. This is your complete diagnosis. And you should have a habit of writing this on your OPD slip so that if anybody else sees your prescription, he also gets impressed that you have written complete diagnosis. Then there's no further question on diagnosis. Otherwise, it just gets prolonged. Regarding the post-band contracture, whether you incise or excise, you want functional recovery, as Dr. Venkateswaran was telling. And for that, you have to have two things. One is the joint movement, other is the element which moves the joint, and that is tendon. And many a times, even if you incise, you should mention about tenolysis, because the tendon is adhered to the overlying scar. And even if you do an excision, your excision always is about 70 to 80%. Some adjacent area you feel that it's soft. I need not excise. Even then, there will be tenolysis will be required. So you free the tendon so that it can act. Regarding the first case, your long case, you are stuck with the question that when you do a transposition, then there will be a dog ear or additional fold. Absolutely correct. So your answer is that when you are moving the lint, it is always a rotation come transposition movement. If you see it very carefully, there will be an element of rotation, even in transposition. So that takes care of the that particular trick of the question. So when you say it's a rotation come transposition, then you are better covered.
Okay.
Third thing is, what do you see in Doppler? You see, you always mention I'll use Doppler, and many a times you have mentioned color Doppler. So audio Doppler and color Doppler are totally different thing. Gives more different types of information. But I will precisely tell you about color Doppler because this is asked in the exam. What you learn from color Doppler? There are 5 things you learn. One is the location of the perforator from a fixed bony landmark. Okay. Second thing is interperforator distance. Third thing is direction of the perforator. Fourth thing is length of the perforator. And fifth thing is internal diameter of the perforator, on which the perfusion pressure depends. Okay, so 5 things you learn. Now, many a times it is asked that what is the perfurosome area or an angiosome area earlier. Now perfurosome is used. Now for that, you must understand the basic physiology. In a normal person, when the blood goes from the intravascular to the extravascular space, so in extravascular, there are two factors, two pools which are favoring. One is the negative interstitial fluid pressure. It is 3 millimeter of mercury. I'm talking of physiology.
Okay, sir.
And the second thing is the interstitial colloid osmotic pressure, which is 8 millimeter of mercury. So 3 plus 8 is 11. 11 is helping the fluid from coming out from the intravascular to the extravascular. On the contrary, the colloid osmotic pressure within the vessel is 28 millimeter of mercury, which is not allowing the blood to flow out into the interstitial tissue. Therefore, 28 minus 11 is equal to 17. So 17 is the negative pressure which is holding the blood from going out. It is not allowing it. So then we come to the specific question that what is then the net filtration pressure? What is that pressure which is pushing the blood out? Now suppose there is a small, mid, intermediate and large perforators are classified according to the Doppler, according to the internal diameter.
Yes, sir.
So if it is small and which is having say about 23 millimeter of mercury, then 23 minus 17, which is holding the blood from going out. 23 is pushing out and minus 17 is holding it.
Yes, sir.
So 23 minus 17, that means only 6 millimeter is the effective or net filtration pressure going into the tissue. Suppose it is intermediate size, say about 28 millimeter of mercury. So 28 minus 17 is fixed. I have already explained you why, which is holding the blood from going out. So 28 minus 6, it will be 11 millimeter of mercury, the net filtration pressure. Suppose it is large, say about 38 millimeter, 38 internal diameter millimeter. Then 38 minus 17, that means 21 millimeter of mercury is the net filtration pressure. So when we are talking about the perfusion pressure and the angiosome area or the perfusosome area, perforator zone area, then you have to classically and scientifically know the internal diameter of the perforator by color Doppler. And then you classify small, intermediate, and large. I just gave you a number. It may be 1 millimeter, 2 millimeter, this way, that way. So then you can calculate the net filtration pressure, and based on that is the angiosome area or perfurosome area. Therefore, if you have a larger perforator at the base, we'll have a larger perfusosome area. Intermediate will have intermediate, and small ever small. And many times what happens is practically, along with large or intermediate perforator, there are small perforators also. Try to preserve them because they will also contribute to the perfusion. So don't try to always unnecessarily skeletonize a perforator. So in many times we don't visualize the perforator. It's not always necessary. But if you happen to visualize and be more, scientific and you want to demonstrate it, then keep the smaller one also, don't neglect them because they are also contributing to the flow of blood and the perfusion agent. So I just thought that I should give you the clear idea when we talk about what is perfusion pressure and what is its relation to the perfurosome area or angiosome area, and which we always talk about because many times the examiner or the other colleagues ask you that what is the safe limit of a single perforator based flap. So to answer to that is that if it's a large perforator, which you always naturally prefer, it is 1/3 of the length of the leg. That means from tibial tuberosity to the mid-malleolus. So if you divide into 3, if you have a large perforator, 1/3 of the leg limb will give you a safe limit of the flap, which is not supposed to necrose. And the last point is that when you come across a larger defect, which cannot be covered by a single flap, and therefore you do a free flap, this answer is not correct.
Okay, sir.
Even larger defect can be managed by 2 flaps. One antegrade, one retrograde, maybe of the same axial vessel, peroneal or posterior tibial, or one half may be covered by an adipofacial flap, other may be by fasciocutaneous flap, one may be only facial flap, other may be adipofacial. So many combinations of constituents as well as vascularity. So if a larger defect is there and you are not able to do a free flap, then also you can manage very large defects by this. So these are my informations and inputs to the postgraduate.